Welcome to the 49th episode of RSM's COVID-19 series, which is for health professionals, by health professionals, and designed to give workers on the front line regular updates from healthcare leaders on COVID-19. There's a Q&A feature that you can ask questions during the session. You can also upvote for questions you'd like to answer via our panel. This session is recorded. Today, we have three excellent panelists exploring the impact of COVID on critical care, and in particular, the differences we're encountering with the second wave on our ITUs. With that, I'd like to introduce my first panelist, who is Dr. Alison Pittard, who's a consultant in critical care at Leeds, and also Dean of the ICMF. Alison was also awarded the OBE this year for her sterling work with COVID, and we're really pleased to have her on our panel. Thank you, Alison.
Thanks.
We also have the pleasure of Dr. Gary Masterson, who's a consultant in critical care in Liverpool, which is very topical. He is past president of the Intensive Care Society. Hi, Gary.
Hi.
And finally, we have Peter Shirley, who is a consultant in critical care at the Royal London, and our own RSM president in critical care. Thank you, Peter, for joining us to make up the trio.
Oh, good morning, afternoon.
Well, thank you to you all. These are challenging times and very interesting times. And I kind of wanted to start off with asking Alison her thoughts on the national perspective with COVID and intensive care.
So I think it's very interesting this second time round because it's very different for a whole host of reasons. But for me, taking a national picture, it's the geographical variation. And so Gary in Liverpool, the rest of the Northwest, Northeast and Yorkshire and the Humber have already been working at a heightened rate for many weeks now, with the increasing number of COVID patients. And other areas, particularly in the south, there's not been that many admissions to hospital or to intensive care. But what's happening now, and obviously what has prompted the national lockdown and the move to a level 4 alert for the NHS, is the rising incidence of COVID patients in other areas, and that then translating into hospital admissions and then critical care admissions as well. And this time round, what we want to ensure is that we maintain our ability to manage everyone with COVID, but at the same time maintaining our normal activity. And I think the concern now is that if the incidence and transmission of COVID continues to rise, then that's going to have a negative impact on everything else that we want to do. So whereas in the first wave, it was COVID and nothing else, we're trying to juggle much more this time. So we're in a better position, but it's much more complicated.
Yes, a real challenge. Wish we had the answer. Gary, I mean, what's happening up in Liverpool? Because you're in, it's a topical area. How are you coping?
Thank you, Nick. Liverpool's always topical. I think in summary, we are coping, but probably only just actually. We've been under immense sustained pressure for almost 6 weeks. Multiple referrals of COVID patients, sick COVID patients. And as Alison says, this is alongside all the usual patients we get referred to critical care, and also smaller impact, but the ongoing elective work, which is clearly important. So we're really trying to do an extra job in looking after the COVID patients, in addition to the usual stuff that comes through the door. Not only that, but last time, during the first surge in March and April, there was very much a sense of all hands on deck. So we literally had members of staff recruited in from all areas of the trust. I was literally falling over colleagues in the critical care units. And it was fantastic, but that's not the case at the moment. It has felt, particularly in the early days, that it's really a problem for critical care ED, respiratory medicine, ID, and perhaps we're a little bit on our own, but I think that's changing actually. And I think there is more and more mutual support, mutual aid coming through the system now.
Good, you're getting more support.
Yeah.
That's the north. Peter, do you have a view from the south?
I think, I mean, as we were chatting before we went live, I think having seen the stuff on TV about Liverpool, to be honest, Liverpool looks like where we were probably in March, all hands on deck, elective work sort of slowing down and being cancelled. It feels a bit different this time in the south of England. We've had a steady sort of increase of admissions over probably 4 weeks, but unlike last time where it was a big ramp up on a daily basis, it seems a lot slower. As Gary's described, we don't have the same level of sort of footfall in terms of other help this time round. And as well as the sort of medical nursing help that we pulled in, we had other support, the medical students, we had a separate team doing communications with relatives. We don't really have that at the moment. And I think, again, as Gary's just alluded to, that will probably have to come whether people think it should or shouldn't. At the moment, I mean, my trust is trying to keep up with its elective output for surgery for good reason. The waiting list has gone up massively over the last few months, but it is going to be difficult. And I think there's now a realization that whilst it may not stop, some areas are going to have to slow down. And again, as we chatted before we came on, we're quite keen locally to try and make sure that everyone still realizes this isn't just an intensive care problem, it's kind of everybody's problem in the hospital. And there is a temptation now for people to sort of go back to their normal work and sort of try and ignore us a little bit, but we will have to be quite vocal, because as the numbers increase, our safe staffing ratios and other things will become difficult to maintain, and then it will become a very straightforward safety issue. And you know, Alison and the FICM have banged the drum about the safe staffing and trying to maintain that as long as possible. But if it isn't possible, we will then have to think about what we can do. We're quite fortunate, I think, in intensive care. I was talking to my wife last night. She's a doctor, she's a physician, and she's not had to be redeployed again yet. But we're quite lucky that we can just look at the patient in front of us to some extent. Some of these bigger decisions around lockdown and other work, I feel a bit more happier this time that they're kind of left to other people, because we do, for us in intensive care, we do just have to look at the patient in front of us, as difficult as that may be. Some of these bigger decisions that we see nationally and sort of both medically and politically, I don't envy the people that have to make them.
A major challenge, and of course, I mean, you're right about it. I mean, COVID is a worldwide problem; it's everyone's problem. So we do have to work together, and that was exemplary on the last occasion. And I think you're right. There's some logistical elements, and that balance between elective and unelective may be something that we have to explore. I might just go towards a more of a clinical question, really. I mean, perhaps a recap. Why is COVID so different to the other viruses that we've picked up in the past? Who would like to take that on?
Shall I go on then, Pete? You go on.
I mean, I'm not an academic. I'm purely a clinician. But my observation of it is, in the outset, we very much perhaps thought it was a respiratory disease, but actually it's a multi-system disease which happens to affect the respiratory system. And I work in a mixed general unit. We're a trauma surgical unit, and we've had to readapt to do a lot of sort of more respiratory care, but the respiratory component of COVID is only part of it. And I think we're only just at the point of understanding that, in terms of, and you've seen a lot of the national things about long COVID and the long route back to rehab, and it's not just about the lungs, it's about everything else. And just at the point we're getting some understanding of that, we're now moving into a second wave. So whilst there's been some understanding, and there's been some obviously sort of work on using dexamethasone and some of the modalities that may modify the disease, there's still no vaccine, there's still no cure, and we're still very much doing basic intensive care in terms of providing support to failing organ systems, which we can do very well. But for this disease, we probably didn't understand at the start perhaps how long we would need to do that to get people through to the other end of it. For other viruses that we deal with, often there's observation. There appears to be a shorter course in terms of resolution or, unfortunately, mortality. Whereas for this disease, it seems a longer tail.
I guess, I mean, there are lessons learned. I mean, Alison, I guess the things that Peter's touched on, dexamethasone, the ways of ventilating. Do you want to make a comment around the positive things that we've picked up?
Well, yeah, because obviously in the at the beginning of the first wave, we were intubating patients very early on, because that was the advice that we got from other parts of the world, in that these patients were sick and there was no point delaying intubating them, because you just ended up with an even sicker, very unstable patient. And then we've learned, for a variety of reasons, that actually quite a large proportion of patients manage solely on some form or other of non-invasive ventilation and avoid being intubated completely. But what that has been translated into is wards full of COVID patients on some form of non-invasive ventilation, who there's very little that you can do about them. So you know, on a ward round, you'll go from one patient to the next, and you look at them and you look at their blood gases and things, and it's okay, more of the same. And it's quite frustrating, because as a clinician, you want to implement some form of treatment or a change and see the patients improve, but we know that a lot of them are in this for a long term, in terms of weeks rather than days. So as Peter's alluded to, they don't have as quick a turnaround in terms of recovery as perhaps non-COVID pneumonia, and that's quite difficult to get a grip of as a clinician, because it's very different to what we're normally used to. But at least it means that patients aren't needing invasive ventilation, which is good. And again, as Pete says, we are much more aware of all the other things that can go wrong, and respiratory complications are just one of the things that we have to deal with. So we are in a much better place than we were back in the spring.
So helpful. And Gary, I might just, I mean, we talked about the patients. How about the staff? I mean, like many areas, intensive care is very multi-professional. How are the staff coping?
It's quite interesting. They are coping, but I think there is always a price to pay. When I speak to colleagues from all specialties, all areas, my nursing colleagues, HP colleagues, there's a standard line: do I have to go through this all over again? Everybody says the same thing. Everyone's thinking the same thing. I think the problem this time, it's not the current crisis, it's not knowing what comes next. It's not knowing when it's going to come to an end. I think that's the real driver for stress at the moment, actually. And I think that really does weigh in people's minds. To be fair, I think that many organizations, trust, have recognized the levels of stress amongst staff, and they have set up various facilities, counselling and so forth for staff. But I think there is a failure of colleagues to always take advantage of this. There might be a slightly macho attitude in critical care medicine that it's never going to happen to me. And that's why it's important we actually look after our colleagues and keep a close eye on people, actually, particularly our trainees, I would say.
And we talked about the well-being and psychological effects on the staff, and everything about experience around patients. I mean, after ITU and after the hospital, what do we do for patients after that? It might go to Peter at this stage. What do you do for patients who've been on ITU and gone through this process?
Well, as we're speaking, our follow-up clinic is taking place, which I've got to say, I've never actually attended, but one of my colleagues runs the intensive care follow-up clinic. We're not quite at the point necessarily of seeing the COVID patients come through that, but that's there's a whole range of assessments that take place at that clinic for any patient that's been in intensive care for more than 7 days. They're offered the chance to come back, and it's right from rehabilitation, finances, sexual health. There's a whole raft of different things, not just the the physical medical things that take place. I don't think we've even touched the tip of the iceberg in terms of seeing those patients. And I've just seen Colette, who does it, go up there just now, and I did actually say to her, are you expecting to see some COVID patients? And she said, who knows? The problem now is that the same staff that help run that clinic are our clinical psychologists, our physiotherapists, and they're all now trying to be busy focusing on the new wave of COVID patients, including the support to their relatives and those patients. So whatever service we thought we could offer is now already being diluted.
And Alison, did you have any perspective on that?
Yeah, I mean, in Leeds, I ran our intensive care follow-up clinic for 20 years, and although I haven't been involved recently, patients with COVID have been, when I say seen, you know, they've been contacted. And what is interesting is that the problems that they face don't appear to be significantly different to the non-COVID patients, but they still need the kinds of support because they still have issues with flashbacks and nightmares. They may need input with rehabilitation. And there are many follow-up services around the country that have never been properly resourced to deal with that. And when we hear about issues about long COVID, it seems to me what I'm hearing from people around the country is that is something that is a particular issue with patients that either haven't been in hospital or at least haven't been in critical care. So they've been much more aware of what's been going on. And there's been a lot of focus on that. And I think it's really important that we don't forget that the patients who have been in critical care will still need to have the normal follow-up that they would do, whether it was COVID or not. But perhaps it's time to actually adequately resource the follow-up clinics around the country that have been established for a long period of time.
Yeah, it's very helpful, isn't it? And one of the areas that also is a topic about patients coming into the critical care is the BAME group and the high-risk patients. I don't know, Gary, do you have any sort of clinical experience that corroborates that?
Do you mind if I just go back to the last point? Because I think there's a point I really, really want to make, and I know I bang my drum about this constantly, but in terms of patient rehab, long-term rehab, psychological rehab, I think the AHPs, allied healthcare professionals, critical care, really are unsung heroes. And the one area that desperately needs funding urgently is the provision of psychological services. We're fortunate in Liverpool, we have some access to psychology services, but that's certainly not universal throughout the country. We desperately, desperately need funding for psychologists. Moving on to your question, Nick, if I may, in terms of BAME patients, there's no doubt that the recently published ICNORC data, Intensive Care Audit Research, National, you know what I mean, Centre, they showed quite clearly that patients from BAME backgrounds are both at risk of severe COVID disease and have a higher mortality. And although I haven't got the data to support that, that's certainly my impression of Liverpool. We certainly have a significant number of patients from those backgrounds, and also a significant number of patients from low-paid jobs, taxi drivers, security guards, all too common, unfortunately. And of course, the BMA, AME backgrounds and lower paid professions are so intertwined, it's difficult to tease out the differences.
There sparks a long discussion on inequalities in healthcare, isn't it? Peter, did you have a view?
I work in a very sort of ethnically diverse part of the country in East London, and our normal patient population tends to be BME, but it was stark during the first wave, going into 3 or 4 COVID bays and not seeing any white patients at all. It was just observationally, it was very noticeable. And additionally, a large proportion of our staff are from BME backgrounds, and I think they found it particularly difficult because they were then, you know, they felt at risk and they could see very visually the risks in front of them. And that side of things was quite difficult to, and I've spoken to staff, you know, both in the operating theatre and the ICU in our hospital recently, and some are genuinely fearful of the second wave because they sort of feel in some way that potentially kind of got away with it the first time, but will they get away with it the second time? And there's all of that overlay on the staff themselves as well as the patients that, you know, we're trying to sort of manage their expectations and you know, be mindful of what they're going through. And just on that subject, I'll just sort of finish with the last point, because we've got a lot of BMA staff, a lot of whom actually come and work from overseas. We've got a lot of Filipino staff from Southeast Asia. Normally at Christmas, a lot of them take extended leave to go and see family. That's their big trip every year. And potentially this year, they're not able to do that. So there's all those other impacts on the staff. And yes, whilst they may still have a job and all these arguments about furlough and things, the personal impact of then going into the second wave and not being able to see family themselves, having dealt with COVID, not once but twice, I think is having an additional impact. So I suspect our psychology and wellbeing service is going to be very, very busy.
Very good point. Very good point about the families. I think that's a social problem as well, isn't it? All groups, particularly those from overseas. I'm going to take an opportunity to, because we've got about 30 questions come in. There's about 1,200 people on the webinar, so we've got a lot of people to address. So I'm going to take some questions, if that's okay. Is there any evidence of variation in COVID strain across the country in terms of transmissibility or disease?
I'm not aware of any evidence to support that. And one of the things that all the colleges have had the opportunity of is to have weekly or fortnightly get-togethers with each other, organised via the academy, where we can get to talk with NHS England via Steve Powis and also with Chris Whitty as well. And obviously Chris Whitty understands the transmission and everything else. And from what he tells us, there's no evidence to suggest that different strains have appeared in terms of changes in transmission, in terms of community transmission and how patients are responding. Now, whether that will change going forward, I mean, I'm sure it will, because that is the nature of viruses, but nothing evident at the moment.
Okay, that's very helpful. I think we did answer this a bit, but the mortality in phase 2 compared to the first wave, significantly different?
Too early to say, I would say, at the moment. It doesn't. The disease that we're seeing clinically doesn't seem like a different disease, so we wouldn't expect the mortality to necessarily be any different. I guess, as we've alluded to before, we're much more cognizant now of continuing into a longer phase with these patients. So it may be some time before we're clearer what the mortality of the second wave may or may not be and whether it is different to the first wave. But I honestly feel it's too early at the moment.
Gary, your thought?
Yeah, I completely agree with both Alison and Peter. It is too early. The data hasn't been collected and published as yet. However, in terms of an impression, I think we have gotten better looking after that disease. I think our current strategy of not jumping in and intubating these patients immediately just because they're hypoxic and using non-invasive methods to support oxygenation is definitely the way to go. Our level 2 satellite unit, which is essentially run by our respiratory physicians and ID physicians with our help, their numbers look very good, actually. And we do put a number of patients in that unit who are not for escalation. And in gross terms, they're doing very, very well. That's less so the case for patients who come to true critical care, the patients who are more difficult to offer CPAP to, and the intubated patients. They still seem to have a significantly high mortality. But of course, the proof's in the pudding when the data will be published.
Thank you for that. There's a number of questions around the Nightingale hospitals. Are they going to be opened? Will they have sufficient capacity? Will they be appropriate for the types of patients we would go there? So, Gary, you're excited by this. Let's go to you first.
I don't want to be negative, and I think in principle, Nightingale hospitals were really a very good idea, but perhaps the thinking was done before we actually had any real understanding of this disease process. And for that reason, I think that largely they're not going to be of tremendous value. Most patients, sick patients, need high flow oxygen or CPAP. By definition, these patients can't really be transferred in ambulances. They're far too difficult to throw in an ambulance and take off to a Nightingale hospital. That's even greater the case for patients who are intubated. There was an impression given because you can stick a ventilator by a bed, you got an intensive care bed space. That's simply not true, actually. Once you put intubated patient, ventilated patient, these patients are often very, very sick and require advanced therapies, proning, nitric oxide, ECMO, and so forth. And I don't think these are the sort of patients the Nightingale hospitals are equipped to look after. I understand that the Manchester Nightingale Hospital, its SOP, it intends to actually look after non-COVID patients, less sick patients. And personally, I think that's a much, much more sensible model. Still has difficulties, but I think that's the way to go. The big problem, and I'm sorry to be negative again, but this is the reality, is that critical care, it's not about ventilator, it's about having the MDT looking after the patient. You need the doctors and nurses, AHPs, multiple other specialities to look after the patients. Now, we're struggling to staff our normal NHS hospitals with self-isolation, with staff sickness, and so forth. How are we going to staff Nightingale hospitals? I really don't understand that. And lastly, and I have to say this, I say critical care, it's not just about looking after a patient in bed. It requires the input of many, many different specialties, even cardiologists on occasion. We need all of these people, cardiology, respiratory medicine, endoscopy, and interventional radiology, to actually do the job properly. We don't have these services, we can't deliver optimal critical care. And I might be mistaken, but I'm pretty sure that Nightingale hospitals don't actually have these other services.
Alison, do you want to come in there?
Agree with everything that Gary said, and I was going to quote my colleague and friend Nikki Credland, who's chair of the British Association of Critical Care Nurses. She bangs on it every possible way. It's about staff. You can't just knit a nurse or whatever. But I'm just interested, Gary, about the Nightingale hospital, particularly in Manchester. The one in Harrogate, I had the opportunity to go round. I mean, an amazing feat of engineering, what people did with a very quick turnaround time. The Nightingale in Harrogate has no external windows and no patient facilities, because obviously it was developed to manage the critically ill. And I completely agree that I don't think we should be putting the critically ill in there. But does the Manchester one have windows? I mean, is it more appropriate for conscious patients? I'm just interested for my own information.
I have not been involved with the Manchester Nightingale Hospital, but I do know the venue because I've seen a number of bands play there in the past. And I can confirm that it's not an ideal environment for awake patients. I can't think of any real windows or anything else, actually. It's basically a big, big space.
Peter, what about London?
Well, the London Nightingale facility, which I actually live quite close to, has been effectively transferred to about 11 floors above me where I'm sitting, because the hospital rapidly expanded 2 dormant floors at the Royal London Hospital and has now got an enormous, in inverted commas, capacity for critical care. But as my colleagues have just alluded to, what hasn't been identified is the safe staffing to go along with that. So at the moment, although it's called, I think it's going to be known as the Royal Nightingale at the Royal London, and it's called Nightingale, it can't really function as a Nightingale hospital in the sense that was suggested in the first wave, particularly because of the staffing issues that we've just spoken about, and also because physically to cram a lot of patients, hundreds of patients into one location in an open area, without the downstream discharge ability to put them in wards and that kind of thing is logistically virtually impossible. So whilst the concept as a sort of rescue therapy seems quite good on paper, the the overall package is very difficult to sort of comprehend. So at the moment, we're trying to limit that area into sort of discrete pods of 15 patients and saying this is what you'll need to manage each pod. And at some point within the building, we run out of staff, the MDT, to run the pods, and so the other pods remain empty. And that's been, I'm not the lead anymore, but other colleagues are managing it in that way, and that seems a sensible approach. The suggestion's been that hospitals could bring patients here and provide the staff, but again, how that would work is that just denudes the staff at those hospitals that are already overwhelmed. So it's a square peg in a round hole, unfortunately.
So a major challenge, certainly is a major challenge. Alison, there's a question on PPE which I've just lost. Did you want to sort of take that on?
Obviously, PPE through the first wave was a real challenge, and concerns about availability and the quality of it. Again, we were very fortunate to be able to have regular updates from NHS England, and so there was a huge amount of work went in to try and procure PPE. And what was absolutely fascinating, sort of seeing what was happening behind closed doors, is that the UK were bidding for PPE in terms of financially against the whole world, and it was going to the highest bidder. And so there was that big story of where there was meant to be a whole delivery of stuff from Turkey. And that was never coming because somebody else in another part of the world had put in a higher bid and it went to them, and we didn't know about it. So, it wasn't for lack of trying. Since then, there is so much work being put in by people at NHS England to procure PPE, and there are now months and months and months of stockpile. And of course, that is continuing to be fed in at the bottom end as it's being used at the top end. And again, all trusts are monitoring their usage and are updating. It was initially during the first wave daily as to what was being required, and deliveries were happening almost on a daily basis, but that's not required at the moment because there's much better availability. So I can say, although it's not my area, from what I've been told, I feel confident that hospitals and organisations are getting the PPE they need in the amount that they need, and therefore for it to be safe for people, then everyone, certainly within the healthcare sector, will be following their infection prevention control precautions and wearing the appropriate PPE. Now, in some places, some individuals may feel that they want to, for their own protection, have a higher level of PPE. And that's absolutely fine. The guidance is about the minimum in terms of an evidence base to be safe. But if some people, for whatever reason, want to wear a higher level, then that needs to be supported, whatever makes people feel safe.
Very helpful. And there's also so it's a very positive message. There's a message from Michael Wang saying that the Institute psychologists has given a website address, so there is work going on providing the psychological support that we discussed earlier on. So opportunity to go and look at that. A question from Dr. Hussain, is there, you've had COVID-19 once, can you get it again? Peter, and then Gary.
Well, I'll speak personally. I've had COVID-19, and I did have antibodies, which have now gone. And I'm advised that I can get it twice. So from a personal point of view, I'll be wearing my PPE with great gusto. There is evidence that you can get it twice, but the reports worldwide are few and far between. There's been a couple of cases reported. I think there was actually a doctor, I can't remember, in North America who was ventilated on their second run through COVID-19. So theoretically, you can. The antibody test is only one aspect of immunity, though. So the T cell immunity, which isn't measured, as I understand it, not being an immunologist, we don't measure that, and so the actual immunity that we may or may not have is somewhat unclear. I know lots and lots of people that have had COVID-19. I don't know anybody that's had it twice.
Gary, have any?
Yeah, I know a few people who've actually had it twice. But to go back to Peter's point, there's more to immunity than simple antibodies. So as he says, we can't measure T-cell immunity. But I'm reasonably confident that we've underestimated the numbers of people in society who have suffered COVID. The number of people I've met who have lost smell and taste and have had negative antibodies is immense, and I include myself in that number. It's been quite debilitating, actually. I can't enjoy my whiskey as much as I used to. but I suspect that in the fullness of time, we will find that the numbers of people who are COVID positive will be significantly higher than we currently believe.
Okay. That's very helpful indeed. I'm just going to move on to another question, which is pretty topical, because it's from one of our ICU matrons. And what's your view on patient-nurse ratio? Because there's a lot of, at that level of critical care, it should be 1-to-1, shouldn't it? But how far have you got down with that?
Off with that, because I can give a national perspective. So in the first wave, it was very much a knee-jerk reaction that we had to make sure that we did everything possible to treat everybody who would benefit from critical care more than the burdens that they would suffer. And so the Nightingale hospitals were created. There were staffing plans put in place to try and mitigate harm that would come to patients. And the only way, because as I've said, you can't knit a critical care nurse overnight. Actually, I know that it took me a week to knit one because I did it just out of interest. That the only way to try and deliver a semblance of critical care service is to do it as part of a team. And that meant diluting critical care staff across the board, doctors, nurses, allied health professions. So the modelling that came from NHS England had at a maximum 1-to-6 critical care nurse patient ratio. So that was 1 nurse to 6 patients, but then there would be non-critical care staff looking after an individual patient. And that's obviously stressful. It's not sustainable. And nobody would want to go back to that. And I'm not sure if anyone got to the 1-to-6, but certainly there were, I know of places that were running at 1-to-4. NHS England, the faculty and the Intensive Care Society want to make sure that delivery of care is safe and is of the highest standards. 1-to-1 is ideal, and that is what we would normally do. But we have to be pragmatic, and there may be times when, depending on what the load and the demand is, that we may need to flex that a bit. And so we are supporting a temporary change to a 1-to-2 ratio. This is going to be published very soon from NHS England, but this will only be on a temporary basis. It's not to support normal planned activity. It's only when the amount of COVID, the number of COVID patients is really tipping people or units over the balance. It's not sustainable in the long term, and it's not to maintain normal activity. And, although we would like to stick to the 1-to-1, in the current situation, we can't. And we felt that was probably the best balance, and we wouldn't support anything more than or less than a 1-to-2 for a short term.
Thank you. We've talked a little bit around new treatments, etc. But I guess, can we give our sort of top tips to avoid getting onto ICU as a COVID patient? What should we be advising our generalists to do to avoid patients going to ICU?
Thanks.
Don't catch it in the first place.
Yeah, I think it's very difficult. I mean, our experience with the first wave was that a lot of our teams really stepped up, and we were overwhelmed with sort of patients coming into the hospital. And actually, what I observed was some very good decision making from the teams about who they were going to refer, who they were prepared to look after, extending what they would normally do. But ultimately, when those patients needed intensive care, and it was generally because of hypoxia that wasn't manageable in a ward setting, it was very clear they needed to come. And there wasn't actually a lot they could do. And as Alison has alluded to, once you've done more of the same, and you know, and more of the same isn't working, then you have to move to something else. And the move within the hospital was generally in intensive care. I guess what, as we discussed before we came on, the danger with the second wave is that we will need all of those teams, particularly respiratory teams, to kind of come back on board and provide the CPAP and go back to that. And I know there's genuine concern about doing that because of the impact on the services.
Gary.
Yeah, I completely agree, Peter. I'm not sure there's anything we can do to reduce the worsening of a patient's hypoxia once the COVID disease process starts. In the fullness of time, there may be some genetic manipulations can be done and identification of relevant patients and so forth, but at the moment, I don't think so. But an allied point, I do sense that patients are presenting earlier in their disease process. During the first wave, it wasn't uncommon to see patients in our ED resuscitation area in utter extremis who required intubation immediately and who often died quickly, unfortunately. The numbers of such patients seems to be considerably lower at the moment. Patients, I sense, are presenting earlier. They're more aware. They're coming into hospital. Perhaps they're slightly less frightened of coming in the hospital. Perhaps NHS England's message has gotten out, actually, which is a good thing. I think this is good. It may be a contributing factor to better mortality rates. We will know once it is published, obviously. It's just an impression.
There, Gary, because you know we've got all the reports that the hospital admissions are in some places now are above the peak in spring, but we're not necessarily in the same place in terms of critical care. And so one of the explanations of that could be, as you say, that patients fortunately are presenting early and we can intervene much earlier. So that's a really positive message to get out, I think.
Apologies there, my internet dropped out. So I'm back on my phone, I apologize. Couldn't script it. So I think one of other questions was what would you say to trainees and doctors that want to take on a career in critical medicine? How do you encourage them to come to ITU?
Brilliant, and we've got 100 more training posts this year, so there's lots of opportunities to come and get involved. I mean, you know, Gary will say the same. He has said today that intensive care medicine is a multi-specialty, multi-professional service, and we need input from a huge variety of people. And I think having critical care skills alongside another specialty. I mean, some people want to just do intensive care medicine on its own, and that's great. Other people would like to be able to share their competencies and skills in a number of different areas. And I think if
I think we may have just gone on mute there and lost our sound.
I can pick up on that while Alison's coming back. Yeah, I mean, myself and Alison were regional advisors together, and both got an interest in education and encouraging people to do intensive care. I mean, I'm an anaesthetist by background. In my unit, we've got respiratory physicians, renal physicians. My colleague that does a follow-up clinic, she purely does intensive care with follow-up. So it's a very broad church. It suits people who want to see a lot of different things in one working day and enjoy team working. The COVID, I think the COVID pandemic has been a blessing and a curse in some respects. We've definitely got doctors who now want to do intensive care. Unfortunately, we've got some who perhaps are deciding that, having seen what they've seen, they don't want to do intensive care, and that's always going to be the case with any stressful event. Similarly with the nursing staff. But I mean, one of the things we've done this time round is we've expanded the number of fellows in our unit who come for just a dedicated burst of intensive care for 6 months out with training, usually at the start of deciding what they want to do. And there's been no shortage really of people wanting to do that. So yeah, we're very hopeful that we can keep people coming. I think that we are fearful, though, that if people do experience a lot of stress and sort of inverted commas burnout, we want to make sure we're careful about mitigating against that.
That's good as well. It's a good advert for people, and as well as being good clinically, as intensive care doctors are, there are some very challenging decisions that need to be made, perhaps ethically. Does anyone want to talk a little bit around who do you choose goes to the ITU unit? Or
I presume you can hear me now.
Yes, thank you. Welcome back.
What happened? I think one of the things that we have tried to stress throughout the pandemic is that decision making should be made based on our normal frameworks, and that is really, really important. I know that there have been concerns about capacity, and we were very, very stretched, but we didn't run out of capacity. It was close, and nobody should be denied critical care if the benefits of that outweigh the burdens. And we're no different now than we were then. What I think is more complex is actually, and more difficult, is having those discussions with patients and their families. And the time to do that isn't at the point of referral to critical care, because that's when there is a time pressure, both in, you've got to make a decision whether you intervene now because you haven't got the luxury of time to wait. And so although you can't give a patient a crystal ball to say this is what might happen, it's about having an informed discussion about what the patient would or wouldn't want, what compromise on their daily activity in terms of quality and capacity, and then decide what the impact of that was. So we could get a referral to say this patient has decided that they would not want to survive if they couldn't do X, Y, and Z. And if we said, well, actually, if they come to critical care, their chances of getting out and being able to do X, Y, and Z is 0, then that makes it very simple. But you can't just do that in a couple of minutes. That takes time. So the discussions need to happen earlier, which then makes our decision a lot easier. And I'm sure that Gary and people say similar things, if not, on the same theme.
Okay, Gary, is that pretty much sums up?
Yeah, that's absolutely how we work in practice. Actually, there's always been worry that should the system become completely overloaded, that reverse triage would need to be considered, but that's a long way off. And if that was ever the case, it would have to be a national decision. That's certainly not a decision that would ever be made by an individual clinician or an individual organisation. This is a new disease. There are difficult decisions to be made about treatments for patients and escalates for patients. And certainly something that we've done, and I suspect it's done everywhere, is shared decision-making, the 3 wise men approach. I think it's very, very valuable to share the burden decision-making. And I would include the MDT as part of that, actually.
Well, Peter, did you want to add something?
Yeah, I mean, I was part of, we formed an sort of ethics group in our trust in the first wave, and although it got a bit theoretical in places, there was quite a lot of discussion. And I think one of the things, there's been stuff in the press recently about this decision-making tool and denying people. I mean, that, as Alison said, that's never ever been the case. We've always had to make decisions in intensive care, like any therapy, like a big operation. Are you going to benefit? Yes or no? And those discussions are quite complex. One of the things, though, in the first wave, we really wanted to make sure in London, being quite a diverse area, both ethnically and financially and everything else, was that if you went to a DGH in the south of London, you got the same treatment offered that if you went to a DGH in North London. And so some of the decision-making trees that were put together were to try and make sure that there wasn't a disparity in what people were trying to do in different places. And as Gary said, with a new disease, that's always a danger, because the perception might be, well, you don't intubate somebody. So if you go to Hospital X, you may not be offered intubation. Hospital Y might offer you intubation straight away. So as we were working through at the start, we wanted to make sure that the decision-making was equitable and fair. And again, I was a bit alarmed when I saw some of the media stuff implying that, people over 80 were denied intensive care. That wasn't the case. We had over 80-year-olds, but the fact of the matter was that if you were 80 with a very significant comorbidity and you were going to get ventilated, your chance of recovery to a quality of life which most people would find acceptable was absolutely negligible. And that conversation had to be had. And in some circumstances, we still progressed to intubate 80-year-olds because actually their comorbidities were such that it was worth doing that. So it has been frustrating, but hopefully this time around there's more understanding that those are the normal decisions that intensivists have to make, and to some extent hopefully it's put us on the map a bit with what we do on a day-to-day basis, not just in a pandemic.
No, I think that's absolutely right, isn't it? It shows the diversity of your role. Other than all the sort of fancy stuff, there's some really hard decisions that need to be made, and a major challenge. I might just go around the panel really just to ask some final thoughts. Perhaps, what message would you, Gary, what message would you give to the public?
Yeah,
what we should do next?
I think so. I think the public need to understand that, yes, COVID can be a very bad disease, but it's not a death sentence. There are things we can do to help patients.
Very good. And perhaps, Alison, what would you say to the staff? Because there is a huge group of healthcare workers who really put themselves out there every day. What would you say to those?
I mean, as a group of clinicians around the country and as a faculty, obviously we are immensely grateful for the help and support that we had. And it was really amazing how everyone came together, worked as a team, broke down barriers, and it didn't matter what profession you were from, what level you were at, you had a role to play, and we were all part of a team, broke down those barriers, and it all merged and blurred together. And I think that is something that we need to hang on to moving forward, because ultimately that improved the care that we were able to deliver to patients, and that is why we're here in the first place. We are aware of the negative impact that had, and actually, we've talked about the impact it's had on critical care staff, but I've spoken to staff myself who don't normally work in critical care, who helped out, who have suffered tremendously, because they'd be talking to a patient 1 minute and then they'd come back on the next shift to find that the patient had died. And particularly for theatre staff, they're not used to patients dying, and that has taken a toll on them. So we need to look after everybody, but we understand the problems that people face, but we want to be able to work together. That is the NHS. We are a national health service, and that's geographically, but also between the specialties and the professions.
Thank you for that. And I'm just going to turn to Peter, because you are president of the Critical Care Society at the RSM, and that section does a lot of good work. What more do you think we should do at the RSM to get the message out there?
Well, again, as we said before we came on, I mean, this series has been fabulous. It's been free, and I've attended a few of these. I'd already signed up to attend this one before I was asked to come on as a panelist. I think, as we've alluded to in the talk, this is going to affect everybody. So whether you're in the RSM, in the history of medicine section, or any of the other things that don't appear related to ICU, I think the impact on everybody, nationally, socially, medically, will affect all of us, and it will affect every section in the RSM. So again, as we've said, we want to make sure that people still understand this is a national problem. It's not just an intensive care problem. It's not just a hospital problem. It's a national problem, and we all need to be involved. I think the RSM is going to have to continue that message probably long after the pandemic's over, because we'll still be talking about it for a long time.
Thank you. I think, and on that, I would like to mention that our next webinar, which is our golden webinar, the 50th, is next Thursday, the 12th of November. Will feature Sir Jeremy Farrar, who will be talking about vaccines and living with the virus. And if you've enjoyed this webinar, please do consider to be a member of the RSM. It's a charity, it needs your support now more than ever. I'd like to wrap up by thanking critical care. I mean, we are privileged to have such specialists in the UK. They've really stepped up in times of a crisis and supported both staff in the NHS, but also the public. And Alison, Gary, and Peter, I'd like to thank you for coming on today, and thank you and your colleagues for the sterling work you've done and the work you'll have to do over the next few months to keep us all safe in the country. I hope you've all enjoyed this webinar, and please have a good day. Stay safe. Thank you very much.